Thank you very much, Yashiko. So this final part is just a little bit about lateral videopharoscopy. Now, this is part of the gold standard of investigations of velopharyngeal function. In fact, originally described were many more views, 4 views, but lateral videopharoscopy is widely used, certainly in the UK and in Sweden, but not everywhere in the world, as you've heard. It is, however, basically a lateral cleft which is moving. And it's a simple, efficient investigation which you can do in children as young as 2 3/4. And the beauty of it is that you have them speaking and you can see the interaction of the entire vocal tract, including characteristics of the velopharynx, the palate, the adenoids, tonsils, and tongue movements. And although there is information which overlaps with your endoscopy, there is also novel information, particularly around the interaction of your tongue and palate. Indeed, I believe it's an essential part of comprehensive modern day management of velopharyngeal dysfunction, as in latter times, surgeons have got turned to secondary palate procedures for the management of velopharyngeal dysfunction. Yeah, sorry, I'm having problems too now. Just to exemplify that, the posterior oral errors can be associated with VPI. So that posterior velar position can actually be tongue humping. Yep, can you not see?
Sorry to interrupt. Yeah, the slide has gone a bit fuzzy. Oh no, that one's great. Yeah.
Okay. Oh, it's come back. Okay, yes. Okay, all right. So posterior oral errors can be associated with VPI, the tongue, meaning that the tongue humps the palate up and you think there is velopharyngeal closure when there isn't. Indeed, you can see pharyngeal placements for your tongue. You can see palatal placements as well sometimes, which can be very helpful. So this is an image of the X-ray suite with a C arm here. And radiographer here, operating the machine, the patient here, and the speech therapist getting the sample. And on the right here, we can see a viewfinder to keep the head still, and this information is recorded. I'm sorry, I can't move forward. Yes, I can. I'm not going to play that in the interests of time and the fact that I have a feeling they may be causing us some problems, I don't know. So when we were speaking last time, we talked about 22q and the importance of this particular syndrome. And it's got other names it's known by, particularly the George sequence. And it has high prevalence, 1 in 2,000 to 4,000 live births, and is the most common syndrome associated with clefting. So it's very important that we recognize it. It's complex, it's multi-system, it's autosomal dominant, meaning it runs in families. There's lots of physical characteristics described, but these are common ones. Congenital heart disease, 75% with submucous or occult submucous cleft palate, often associated with characteristics velopharyngeal dysfunction as well, meaning no adenoids, big spaces, no movement of the lateral walls. Immunodeficiency, hypocalcemia, and in children, severe feeding problems, so they often see therapists specializing in dysphagia. And they have subtle dysmorphic facial features, and I would urge you to go to the Max Appeal site to familiarize yourself with the look of these children, because you will recognize them. And similarly, the 22q site in Philadelphia. From our perspectives, they have sometimes significant developmental delay, mild and sometimes moderate learning disability, attention deficit hyperactivity disorder, autistic spectrum disorder. And as they get to their later school years, junior school years, anxiety and depression, and which really comes into play in adolescence, and about 25% go on to develop schizophrenia in adulthood. And one of the real challenges about this condition is it is an evolving condition. So these physical problems actually preoccupy families in those preschool early years. And then they get to school and suddenly these are all becoming problems. And then, of course, as they grow, these issues can be very significant. So it's a challenging condition. But why is it particularly relevant for us to talk about today as we talk about assessment? Firstly, these children can present with severe hypernasality, and almost every target, every pressure consonant can be a glottal stop or a pharyngeal fricative. And actually, if you hear that pattern, and you may be the first professional to see the child, if they haven't had that history of all those medical problems, because they don't all have those medical problems, although they're common, it can be a diagnostic indicator of 22q. So if you see that pattern, just ask the question. The speech diagnosis is complex with those characteristics we've described before all coming into play. And the other aspect is they have significant receptive and expressive language impairments. And some children may be nonverbal until 3, 4 years of age. And other children have good language in these early years, but their language deficits start to emerge in school. But the significance of that nonverbal piece around expressive language delay is, of course, we need children who are speaking to do our BPI assessments, or at least to have single words as a minimum. And therefore, often this has a delaying factor for getting in and starting to assess velopharyngeal function. And I've already alluded to the fact that it's a complex etiology, and as its result of that is surgically, often they need more than one procedure, and sometimes we have to accept some mild hypernasality. Our main aim with them is that they get intraoral pressure so we can get their speech intelligible. And actually that brings us nicely into the final part, which is about the broader aspects of speech assessment. So there's been a move to really understand that we need to move beyond the impairment towards client-centered outcomes, those outcomes that matter most to patients and their families. So it's actually really thinking about, okay, you have a speech impairment, how does it affect you? And we know that children with BPD and their parents perceive a more negative quality of life. So if we go back to this, we can see that intelligibility and acceptability sits under activities and participation, things around satisfaction, quality of life, your communicative competence, and the impact of all of this on your daily life. So let's explore that a little bit further. So if we look at activity and person-centered speech outcomes, it's quite interesting because historically, Cleft speech and language therapists have tried to develop scales on intelligibility, acceptability, understandability, but those are scales rated by the therapist. What we want is the person to tell us about their intelligibility and the impact. So we've adopted the McLeod et al. Intelligibility in context scale very widely in Cleft, I believe now. This is a validated parent report measure, and it captures communication with 7 different partners. It's been validated in several languages and is available in many languages. So do look at that website if you're not familiar with it. Okay. Then participation. Well, Halfstam and Lomander drew attention in Cleft to the importance of the communication exchange, the speaker's message and the communication partner, their impressions and responses. And Stock and Farragon talk about poor speech affecting communication participation of the speaker and the partner, but that it is not a straightforward relationship. And yes, I forgot to point out that actually on the ICF, we've also got other factors, haven't we? We've got the personal factors of the speaker to take into account. And in this instance, perhaps the variation in resilience of a speaker, and also environmental factors. So, you know, are you speaking face to face with someone you know, or are you speaking out loud in a group of strangers, for example? All of those things play into participation. There has been work by these groups on mapping cleft lip and palate management onto the ICF CY codes. And I can only talk about English here. There are some tools to measure participation, the focus, and a shortened version here. And also McLeod has questionnaires that are available to capture participation and the views of the child. So worth looking at. Finally, we wanted to talk about patient-reported outcome measures, which are again very popular, certainly in our health service in the UK. So patients tell us what they think about their outcomes. And in terms of velopharyngeal function, Skirko and colleagues in Seattle have developed the Velo, and there's one for parents. So one of the questions, I find it difficult to understand my child, and one for the child and young person. I get sad because of how I talk. Klassen and colleagues from Canada have validated the Cleft Q. This consists of 14 different scales, of which there are 2 speech scales. And this has been validated by testing it with 2,000 people with cleft lip and palate, both in low and middle income countries and high income countries. So its validity has been well established. The speech scale targets how the patient thinks about the mechanics of their speaking. So I need to try hard to speak well, or I need to speak slowly to be understood. Whereas the speak scale focuses on the psychosocial effects. So my speech makes it hard for me to make new friends, or I worry that my speech is hard to understand. So that's a little bit about the sort of other aspects of assessment. So our final slide, if we can get to it, yes. The clinical speech assessment in Cleft BPD then involves the detailed assessment required for a clinical assessment using transcription, and to look broader at activity and participation. The importance of the oral examination, and that's probably applicable to all children with speech sound disorders, in fact. Determining the etiological factors and referring on for further assessments, making a differential diagnosis, and this underpins your therapy program. And your perceptual assessment can be the indicator of a structural anomaly or a syndrome, allowing you to make the appropriate management. And thank you very much for your attention.
Great. Thank you very, very much, Debbie and Yoshiko, for 2 very excellent presentations. And there's a lot of good content as well. Yoshiko has very kindly agreed to re-record her part. So we will upload Yoshiko's part, re-recorded presentation. I will now hand over to Suraj, Trina, and Judith, who will run the Q&A session. Thank you.
So I think Judith, I'll do the first question if you like. Okay, so one question: should children with oronasal fistula undergo oral surgery?
Who are you asking? Yoshiko, you answer?
Yeah, if it's symptomatic, I will tell the surgeon to do the surgery for the child. If it's not symptomatic, we'll discuss with the team. Anything to add, Debbie?
Yes, I would add that we know that when children with unilateral cleft lip and palate and bilateral cleft lip and palate are born, are repaired, the surgeons would deliberately leave a gap at the very front around the teeth, and that will be corrected when they have a procedure called alveolar bone graft around the age of 8-9 to do with dentition. So that group, largely, we certainly don't advocate having early surgery unless we're really sure that that is the source of air leak, but that is unusual. Mostly fistulae that are problematic, as Yoshiko said, are the ones at the junction of the hard and soft palate or the soft palate, or very, very large fistula.
Another factor in this is the size of the fistula. Sometimes surgeons say that to close the fistula before alveolar bone grafting can put tension on the growth of the maxilla. So that may be an issue in terms of closure. And the other thing is, if there's not enough tissue there, the closure may open up after surgery. So again, you're left with the results of a fistula.
Okay, so next question, this will be for Debbie. Is Gospass 98 freely available, or does it need to be purchased? If purchasing, please can you give details about cost and publisher?
Yes. So the actual articles are published in the literature, and the form is available as well as part of that article. I mean, if you want a better one, then we can put one on the website actually, so you can download it. The teaching DVD that goes with it, you do have to pay for that, and that money goes to the Parent Association in the UK actually, who've originally funded it. It isn't terribly expensive, and details of that will be put into the resources.
So one of the questions is, will there be a certificate after this particular program? If somebody would like to answer that.
Valerie, do you want to take that?
I can, yes. It would be possible if you could send a direct message to Alice in the chat room, or if you could send us an email. So we can organize for that.
Thank you. The next question is, how can we work on correcting nasality for children with good stimulatability in telepractice?
It's a very, very good, interesting question. I think this is really a question for our next webinar, in fact, which is going to be held not very long into the future. I don't know whether or not we want to go down that route today. But Valerie, do you want us to, or?
I'm going to have to ask Judith to repeat the question.
The question is, given that you have a child that is stimulable in terms of reduction of hypernasality, what would be something that you would do, and can you do it in telepractice?
Well, Judith, myself, and Christian will be covering treatment, the do's and the don'ts, in March. So maybe we can save that for the third webinar. I'll take note of that question. Thank you.
Okay, another question. Besides the images captured during video fluoroscopy, is there any form of documentation that can be used to capture the results obtained, or is there a report done? I think was you did video fluoroscopy, Debbie?
Yeah, I did. So I think the question is there a form to capture the characteristics of video fluoroscopy? That's what I think the question means. Indeed, there are lots actually published in different Cleft books. We've recently published one in Anne Harding Bell and I in a text called Case Studies in Cleft Palate Speech, and we'll make note of that. Case Studies in Cleft Palate Speech. Sorry, just had to go and look at the title. We'll make note of that in the resources. And yes, you're correct. There is a report that is done to summarize those important factors.
I don't see any more questions coming in, but there's lots of people saying thank you very much. Very informative, great presentations. So thank you both very much. Anybody else has any more questions? We have another few minutes.
I mean, if we have time, we could explore a little bit the question about the nasality, if you wish. My thinking is, I look at your question, and my first question would be, if there's something stimulable, is this to do with consonant production? Is this an active nasal fricative that's stimulable, or is it the nasal vowels and sort of suprasegmental aspects of speech? Because apart not taking on the telepractice piece, but just that idea that usually if it's nasality, then that's normally associated with a structural problem, meaning nasality that's suprasegmental, so it goes across consonants and vowels, and it's rather unusual for it to be sort of phoneme specific, if you like, a learnt behavior. So I think, but here you're saying it's stimulable, which makes me think, is that a consonant stimulable? So lots of questions come out of your question.
Hello, ma'am. Good evening. Good evening, Debbie, ma'am. This is Sriram. I had asked this question.
Right. Excellent.
Thank you for the presentation, ma'am. It was really wonderful. So the reason I asked this question is I'm currently dealing with a child of a 5-year-old in Delhi, and so she's very stimulable. She's learning the pattern really quickly. So my doubt was related to consonant productions, especially on P, T, K, and all these sounds. So how do we try to focus on the nasality in daily practice, because it is something difficult to interpret? So that is why I asked this question.
Okay, so what you're saying is that it is it the production of sounds that she's stimulable for?
Both the perception and the production of the sounds.
Okie doke. So it is about therapy for those. I think the question is around telehealth, actually, and those characteristics, and using telehealth for those characteristics. How easy is it for her to hear them? And make changes that you can hear? I mean, what would make it different, your therapy in telehealth, to being face to face, I suppose?
Can you repeat that question again, ma'am? I didn't get to.
I'm just trying to work out, is it a telehealth question, or is it a question about the therapy?
It's a question about the therapy, ma'am, more than the telehealth, actually.
Yeah. Okay. I don't know if any of the committee want to comment on this question, but it sounds as though it's working on her sound system that you're trying to do. Is that right? And in so doing, trying to reduce her nasality. Am I right?
Yes, ma'am.
I mean, I think one thing to say is that children who, for example, are using lots of glottal stops will sound hypernasal. If you get them to be using these sounds like p, t, k, you can actually really eliminate some of that hypernasality if structurally they're able to get closure, which sounds as though that is the case for this patient.
So, so I think I'd like to add a little more on this. So this is someone I'm seeing with Dr. Suraj and myself. So myself and Dr. Suraj are seeing this patient together. I'm seeing under his supervision. So this child actually, she's very good in learning the sounds quickly.
Yes.
She has picked up the production wise. She's able to produce the sounds. So my doubt is, how will I be able to focus on the nasality aspects?
Okay, I've understood. Okay.
Yeah.
Well, in my view, what I would want to do is to probably look at her velopharynx during speech as she's doing those sounds, because I wonder whether or not she has got some VPI there. If she's got the sounds, but she's still hypernasal, then the question is it a structural nasality, or which is the most likely scenario, I would say.
Okay, ma'am.
Okay.
Okay, ma'am.
I'm very, very happy to talk to you offline about it. No doubt with Suraj.
Thank you,
I've
ma'am.
had some, I don't know if this would help, Sriram, have had some older patients operated on quite late, and we managed to move all the glottals to oral type phonemes, but because there's still VPI, there's always going to be that overlay of hypernasality on their vowels and voice sounds for these particular patients.